Hi, I'm Donna Gairns, the National Lymphoma Nurse Manager with Lymphoma Australia, and we're here at ASH 2019 in Orlando, Florida. And I'm joined this morning by Dr. Collin Chin, and he works currently at MD Anderson Cancer Institute in Texas. But he did recently, where I met him, at Peter Mac recently in Australia. So, welcome. Thank you for coming to join me this morning.
Thanks for the opportunity, Donna.
Uh, Now, you did chair a session a couple of days ago here at ASH with the aggressive lymphomas and looking at some of the CAR T cell therapies that are coming through across the world. Can you give a bit of a comment and a bit of an overview of that session?
So, the session from Saturday was very interesting and very exciting. And what was presented was a combination of some updates on the current FDA and TGA approved products, including Axicel or Yescarta, as well as a pipeline of new CAR T constructs, including bicistronic CAR Ts, as well as new constructs like ACTR, which are very exciting in the field of aggressive lymphoma therapy, particularly for patients with relapsed or refractory disease.
Excellent. And what sort of results are they seeing with that product?
So with the one of the new anti-CD19 CAR T cell products, liso-cel or lisocabtagene ciloleucel, which is another product similar to Kymriah or Yescarta, we're seeing basically almost equivalent outcomes in terms of efficacy and treatment persistence and progression-free survival when comparing the different products. One of the selling points for liso-cel, which I thought was very interesting, was that unlike the other two FDA or TGA approved products, it comprises a 1-to-1 fixed ratio of CD4 to CD8 CAR T cells, thereby reducing the risk of severe cytokine release syndrome and neurotoxicity. And this was seen in the trial results, with significantly reduced severe CRS and neurotoxicity seen at 2% and 10% respectively. So I think with these results, liso-cel should be getting accelerated FDA approval very soon in the United States, and hopefully also allow us to deliver CAR T cell therapy as an outpatient rather than an inpatient setting.
Can you explain a little bit about the two different CD receptors that it's working on and why it has a less CRS profile?
It's a good question. So the lyso-cel construct is different to Kymriah and to Axicel. Firstly, because it uses a 4-1BB co-stimulatory domain, so similar to Kymriah, but different to Axicel. What that means is that it has a slower expansion kinetics, so expands slower, but in theory, it should actually persist for longer and should have lower risk of late relapse. The other difference is with the fixed 1-to-1 ratio of CD4 to CD8 T cells, that should actually reduce the risk of severe cytokine release as well as neurotoxicity as seen in preclinical studies. And that's starting to be seen in this phase 1-2 study, which is very exciting for patients who are going to receive CAR T therapy because it makes it safer and also reduce healthcare costs for inpatient therapy as well.
Excellent. Can you just explain some of the toxicities that patients can get with CAR T cell therapies? Because it isn't without some serious side effects.
Absolutely. So, some of the unique side effects that we can see associated with CAR T cell therapy include that of cytokine release syndrome and neurotoxicity, or what we call off target effects. Now, these are natural responses of the body to an autoimmune response and can resemble an autoimmune response to a really bad infection or inflammation. Now, some of these reactions can be life threatening, especially grade 3 and 4 toxicity, whereby patients may need to be transferred to the intensive care unit for blood pressure support medicine and very rarely be intubated. And therefore, a main focus on some of these clinical trials is to look how we can mitigate the risk and improve the toxicity profiles. And that's why it's very important that these trials look at creating CAR T constructs that are much safer than the initial CAR Ts that have been established many years ago. And so liso-cel or lisocabtagene ciloleucel does represent one of the first CAR T cell constructs, which represents our maturing understanding in terms of the biology of CAR T cells and how our bodies respond to them.
Oh, excellent. Are there any other new products that you know of in the future that might be coming up that have even less or safer profile?
So, in the oral abstract session, there were two additional products that were presented. The first one was something called ACTR, and Dr. Javier Munoz from the Banner MD Anderson Cancer Center presented on this. And ACTR is a unique CAR T cell product in that instead of targeting tumor antigens like CD19, it targets antibodies instead. And when used in combination with rituximab, which is an anti-CD20 antibody, it showed promising activity with durable complete responses seen in high-risk patients, including one patient with double-hit lymphoma. Now, the reason that this is important is because ACTR was shown to have a favorable risk profile with cytokine release and neurotoxicity, and in future may be able to be used synchronously with multiple different antibodies of different specificities and therefore may overcome resistance. Now, one of the drawbacks from this finding was that there were some unique side effects seen, including visual field defects and demyelination, so a lot more understanding is required for this new construct. The other construct that was presented was a bicistronic CAR T cell construct called Auto3 by Dr. Kiran Ardeshna from London College University Hospital. And what Auto3 represents is a unique CAR T cell where not one, but two CARs are transduced via viral vector to the surface of the cell. So what happens is that it dual targets both CD19 and another antigen, CD22. Now, it's only in its dose escalation phase and still recruiting, but it shows early promise in terms of efficacy and a favorable safety profile, so that these results, which are maturing, are much awaited in the next coming years.
Well, that sounds fantastic to know that there's a lot more development going ahead. There's been a couple of presentations through the conference about therapy prior to getting CAR T, so for bridging therapies. Can you make me comment on that and how that can affect a patient's response?
So the oral presentation that was presented by Michael Jane for the US CAR T Consortium demonstrated that despite having propensity matched populations of patients who would received axi-cel for relapsed refractory large B-cell lymphoma, patients who received bridging therapy had worse progression-free and overall survival. Now, it was quite hard to interpret this data because of its retrospective nature, so limited by confounding and selection bias, but one may suggest that this may be due to a different disease biology or different patient factors for patients who actually require bridging therapy, more so than the actual selection of the bridging therapy itself. What was observed was an increase not just in relapse-related mortality, but also non-relapse mortality. So this really has to be evaluated in a prospective study rather than in a retrospective manner.
Oh, totally. And as you mentioned, basically we're learning more and more about these therapies and what affects it too. So moving forward, we'll be able to treat these better. Have you had a lot of experience at MD Anderson with CAR T?
Yes, so MD Anderson represents one of the largest US cancer centers and recruited a large number of patients for the Zuma-1 trial for axi-cel. And so the total number of patients treated as standard of care have exceeded 200 now. And so we have a lot of experience, hands-on experience with axi-cel. Now, one of the toxicities that we do see is cytokine release as well as neurotoxicity, and with axi-cel compared to Kymriah happens at an earlier stage due to the rapid expansion kinetics from the CD28 co-stimulatory domain. Now, what we've learnt so far and what we've seen in the evidence presented at this year's ASH is that preemptive steroid use, particularly in axi-cel, has been shown to actually reduce the rates of severe cytokine release and neurotoxicity without actually interfering in the treatment efficacy or the persistence of CAR Ts or progression-free survival. And this was presented by Dr. Max Topp from Würzburg University Hospital. Now, this is very significant because neurotoxicity and cytokine release syndrome are serious side effects and have caused deaths in both clinical trials and standard of care, although rare. And therefore, a lot of work has to be done to try and understand this. And we know now for a fact that the anecdote we use in terms of avoiding steroids due to the lympholytic effects and possibly compromising the CAR Ts may not actually be true. And therefore, this presentation that was presented by Dr. Max Top is really important and should hopefully make CAR T therapy much safer for not just Axi-cel, but also the upcoming CAR T products as well.
That's excellent to know because it has been an issue, but knowing that we're understanding more again about these side effects and how we can treat them, that's fantastic. I just thought we'd just finish off by thinking, talking about some of the trials that you're running at MD Anderson and what that looks like for patients in the future.
Yes. So, in terms of the trials for CAR Ts, are performing trials using the existing CAR T products and also CAR T products in the pipeline. With existing CAR T products, we are still investigating the role of Axi-cel as well as Kymriah, and currently they are FDA approved in the United States for relapsed or refractory large B-cell lymphoma after failing 2 or more prior lines of therapy. One of the key topics now is whether or not this can be brought forward to patients at first relapse, because the standard of care is autologous stem cell transplant with high-dose chemotherapy and salvage chemotherapy. So several trials and different products are being run. The ZUMA-7 trial, which ran both at the Peter MacCallum Cancer Centre and MD Anderson, has finished recruiting, and the preliminary results should be available by next year. But essentially comparing on a one-to-one randomization, Axi-cel versus standard of care stem cell transplant. The other companies, including Novartis for Kymriah, are also running a similar trial and similar design called Belinda, which is also running at Peter MacCallum, as well as Fiona Stanley Hospital in Perth, looking at the same question. And lyso-cel liso-cel has also been investigated in a separate trial. So currently in MD Anderson, we're recruiting on 2 trials in first relapse for aggressive large B-cell lymphoma in this setting. One of the other exciting trials is the ZUMA-12 trial designed by Dr. Sattva Neelapu from MD Anderson, looking at the role of early CAR T-cell therapy in high-risk large-cell lymphoma, meaning those who don't get a good response after 2 cycles of chemoimmunotherapy. And typically, these disease biologies we see are those with double or triple hit lymphoma or high-grade B-cell lymphoma. And this is still recruiting in both Peter MacCallum as well as MD Anderson Cancer Centre. So great opportunities for patients in Australia as well as the United States as well. Now, a number of CAR T products are in the pipeline, including bicistronic CAR Ts, but they're still in early phase clinical trials in phase 1 studies and should be recruiting soon at MD Anderson.
Oh, it's lots to know and lots to learn, and again, fantastic to know that there's so much more coming along, and we've come so far. Roughly how long has CAR T cell therapy been around?
So in the United States, for clinical trial practice, it's been around for more than 5 years now on clinical trial. But as standard of care, it's been around for just over 2 years, having received FDA approval from the ZUMA-1 trial for Axi-cel and the Juliet trial for Kymriah.
Excellent. So it's still pretty early stages, so it's great to see so much work has been put into this area. Thank you so much, Collin. I really appreciate your time, and I hope you enjoy the rest of your meeting.
Thank you. Thanks for the privilege.